So good morning. Welcome to NUS and for spending a beautiful Saturday morning with us to celebrate 20 years of population health science. I think many of you are here today because at some point in the past 20 years, you have taken the decision to come forward to take part in a scientific study for us to understand how our behavior today affects our health later on in life. Such scientific studies, or what we call cohort studies, take many years, often decades, for the data that you kindly contributed to provide useful and important insights on how we can protect, maintain, and improve our health. By combining the information provided by each and every one of you, we start to observe clear patterns that have a link with good health or also a link with the onset of diseases such as diabetes, cancers, and even poor mental health. These patterns could be how our genes are similar or how we share certain behaviors in lifestyle related to the way we eat or the amount of exercise we do. And in my opinion, seldom is there a branch of human health science that has a direct impact to the way we live, providing important lessons to look after the health of people throughout your entire life, from the moment a child is conceived and born, all the way to when one becomes old and elderly. Today, you will hear from many of my colleagues on how your contributions have actually benefited the different areas of sciences in human health. And they will not have been able to make these discoveries if not for your participation all these years. Your participation has actually also allowed us at the school to work with the Ministry of Health to understand the importance of waging a war against diabetes, to realize why we need to find ways to reduce the amount of salt that we take in our diet, and even how new technologies such as the screening of your genes can help to tackle conditions such as high cholesterol and cancers that run in the family. Cohort studies have always had the unique opportunity to understand and evaluate the impact of health policies and also provide the evidence needed to formulate good, effective policies for a country. These days, my colleagues at the School of Public Health have also used your cohort, your participation, to really understand how we as a country respond to national programs such as Healthier SG. All this provides us with the opportunity to improve the health and well-being of people in Singapore. It is thanks to you as participants and also to your family for being supportive of your participation that population health sciences have been able to progress. But just as how I've spoken about how many of you as volunteers have contributed to the success of these studies, I would also like to take this opportunity to acknowledge the vision and the hard work of public health professors. Many sit quietly among you today. Some of them are a little bit older now compared to when they first started the cohort study. And without their dedication and commitment to focus their research on improving the health of the people, we will not have the knowledge and insights today. There is also an entire army of staff, many of you would have seen as you come in today, that help with operations, people who handle tissues, biospecimens, the data management team, all of these people who have worked hard behind the scenes to allow the success we see today. So thank you to the professors and the staff members, you know who you are, for your vision in human health sciences, in cohort studies, and your contributions to improving population health. So today we are gathered here to celebrate 20 years of population health sciences and a chance for all of us to see what the fruits of our labor has produced. So thank you, all of you, for taking the decision to join us in this journey. We have certainly not reached the end of the journey. This is at most, in my opinion, midpoint. There are many more new discoveries that can be made. And I expect we will come together again 10 years later to share even more discoveries and policy impact when we celebrate our 30th year anniversary. But for today, let us look back and celebrate 20 years of the Singapore Population Health Studies. So please enjoy yourselves today, and thank you once again for joining us on a journey and on a beautiful Saturday morning. Thank you.
Good morning, everyone. Professor Ying, Dean of Swee Hock School of Public Health, distinguished guests, ladies and gentlemen, great pleasure to be here to celebrate the 20th anniversary of Singapore Population Health Studies. First of all, I'd like to thank Singapore Swee Hock School of Public Health for being a key institution for population health studies in Singapore. We established since 2011, slightly younger than the population health studies, but I think you make a great impact through your education programs, your research initiatives, also your international collaborations. And today, I'm always very happy to see when I travel and I see people overseas saying that I've been to Swee Hock School of Public Health. I did my master's there. And so you have an eminent network of good people out there internationally. And there is also why population health initiatives, because of your contribution, have been implemented recently in Singapore. Namely, we got Healthier SG, we got Age Well SG. We are establishing a stronger pandemic response system, all because of the whole healthcare system working together and with the contribution of the Swee Hock School of Public Health. And I look forward to your continued contribution to Singapore population health. Secondly, I want to acknowledge and thank all our volunteers of the health cohort studies. Many of you are here today. You contributed blood samples. You shared details about your daily habits and diet. Some people are very secretive about them, but you came forward and shared with us what you do. And these contributions enable our researchers to measure data such as your sugar levels, your blood sugar levels, your cholesterol levels, and then also even decode genetic data. And then when paired against your lifestyle information, how you eat, how you sleep, how you exercise, it gives researchers tremendous insights into population health. It gives us tremendous ideas on how to develop population health initiatives to help our population becomes healthier. A notable initiative coming out of the studies is the Healthier SG Cardiovascular Disease Risk Calculator. It estimates a patient's risk of developing coronary artery disease and in turn determines your care plan. Then the wealth of data amassed by the SPHS has also paved the way for other groundbreaking national initiatives, such as the National Precision Medicine Program. In short, without your participation, there's no data, no basis for research, no basis for studies, for initiatives, and for healthcare policies. So thank you very much for all your contribution all these years. Thank you. I think we are in a golden age of population health. Why do I say that? Because of technology. Technology allows us to collect data. AI technology allows us to analyze data and gain insights in a very efficient way, unprecedented. And because of that, and at the same time, it's also driven by an aging population. The whole world is aging, except Africa. Everywhere in the world is aging. In America, Latin America, Southeast Asia, China, even India, more people are getting old than new people are being born. Except Africa, it is still growing with more young people. So as the whole world is aging, some are aging a lot faster than others. The whole world is looking at how to keep their population healthy. It becomes a big healthcare imperative, the top priority of healthcare systems all around the world. But technology now allows us to do that because of data, because of AI. And if you are bold enough, we implement the right population health policies, we can intervene and keep people healthy even as they age. And so that healthcare system do not have to scramble and be under so much pressure to continuously try to treat illness. And I mentioned earlier, all this is not possible without data, without you contributing data to us and able for scientists, professors to develop initiatives and develop insights. I recently made a speech about what we are doing about technology and population health. And we are doing a lot. I just briefly recap what I mentioned and what I announced. We are developing new legislation to govern the use of genetic and genomic test data. We have strengthened our cybersecurity to protect this sensitive data. We are encouraging ground-up innovations by our public health institutions using AI technology to better operate, to better treat patients for better outcomes. At the same time, we are driving major nationwide use cases, including the development of predictive preventive care, such that in future, when you see your Healthier SG doctor, using data, the doctor can advise you are at a particularly high risk of developing, say, diabetes, or even having a stroke, or having a heart attack. Therefore, take preventive steps now. And the preventive steps are simple steps, often involving your lifestyle, your diet, your exercise. These are things that we can start to develop, and as early as in a year's time. So today, I won't repeat all that, but let me talk about 2 additional initiatives that will leverage data to improve population health and strengthen seamless healthcare delivery in our system. The first has to do with the individual. The second initiative has to do with the broader IT system. So let me start with the individual. We can better leverage personal, medical, and lifestyle data to better enable you to take care of your own health. How do we do that? Today, wearables, health applications have changed the way individuals monitor and shape your lifestyles. Riding on this trend, our Health Promotion Board, they constantly refresh their Healthy 365 app, and about 1/5 of our Singapore adult population are actively using the Healthy 365 app every month. So with Healthier SG, individuals can now view their health plan and essential medical data using the Health Hub app as well. So we've got 2 powerful apps that I hope everybody has. One is the Healthy 365, which tracks your daily exercise and physical activities, and second, Health Hub app that actually contains your essential medical data. From end of November, the health plan will be enhanced to become more personalized. You go to your Health Hub app, you are able to see your health plan if you have joined Healthier SG. This health plan will now become more personalized. For those enrolled in Healthier SG, your family doctor can provide more specific and practical diet and exercise recommendations during the consultation. For example, your doctor may recommend that you do aerobic activity of a certain intensity, certain frequency, certain duration each time. Your health plan will now show you the types of exercises that you can do, as well as the resources available in the community, around the place you live. So I hope this will become the advice will become a lot more practical. If your doctor makes dietary recommendations, you will highlight which foods to limit and the healthier alternatives you can opt for. But I'm afraid it is unable to recommend you which store, which restaurant to visit yet. Yeah. The one you have to choose. Yeah? But it can be quite specific. What can you eat? What should you cut back? HPB continues to explore technology and wearables that will help shape healthier lifestyles as well. So HPB, for example, they periodically call for collaborations with private sector partners to develop various techniques to help ourselves stay healthy. So one such initiative arising for a call for collaboration in 2022 is the HPB's partnership with Google and Connected Life. Connected Life is a software company, as well as Fullerton Health, which is a corporate healthcare provider. So under this pilot project, the mobile app will combine patients' clinical data, such as your BMI and your blood pressure, and lifestyle data, such as the level of physical activity collected through your trackers. And this data is accessible then to the Fullerton Health doctors in the dashboard. So they will review them and engage in deeper conversations with individuals on the changes and the improvements required. So we are connecting the dots together, through your Healthy 365 and through your exercises. It captures the data in your tracker. At the same time, through your Healthier SG, all your measurements of your medical data is captured in Health Hub, and all these will appear in a dashboard for the doctor at Fullerton Health to review, and the consolidated picture will allow them to have a deeper conversation about how you should keep yourself even healthier. So this is a pilot, and I think if it's successful, we should indeed look at how this can be broadened and scaled up to the entire Singapore. In a similar spirit, HPB is in collaboration with Abbott. Abbott is a pharmaceutical company, and Health to Seng, which is a healthcare startup, to roll out a health coaching program. And this incorporates a continuous glucose monitoring device for individuals at risk of diabetes. Continuous glucose monitoring device, CGM, is essentially a patch. You have seen them. You stick it on your arm, and it enables individuals to link the patch to an app to monitor your glucose levels across the day and better appreciate how your glucose levels change with food choices and activities. It is actually quite effective in the sense that whenever you eat a piece of cake, straight away you can see your glucose level jump. Then you eat halfway, you'll be scared. Okay, better stop eating. Yeah, ice kacang, eat halfway, you'll stop. Exercise, you'll find that it's dropping or exercise more. So that direct feedback has been useful. So using CGM devices to change lifestyle habits for individuals at risk of diabetes, however, so far has been proven to be quite expensive. The patch is not cheap. And therefore, when we did our studies, we find that it is actually not cost-effective all these years. But nevertheless, we continue to try out new pilot projects, and I believe, and I hope, with sharper intervention techniques and more competitive pricing of the devices with more players in the market, we hope that this intervention over time can become cost-effective. If it becomes cost-effective, then it can be better supported and used more widely. So this initiative is another attempt to hopefully over time develop it to become more cost-effective, that we can make available to more people. Let me move on to the next initiative on population health, which is about the broader IT system. We have been enhancing and expanding our National Electronic Health Record System. This is called the NEHR system. It's a national system and a common platform where healthcare providers can access essential health data of patients. And that includes your diagnosis, your medications, your lab test results, and also your drug allergies. So when we use our Health Hub to access our data, we are really taking a peep into the NEHR system to look at our own data. So all the data in Health Hub draws from this national NEHR system that we have developed. There are immense benefits to having such a centralized repository and data sharing platform. Immense benefits. Patients, especially those with chronic or complex conditions, you often have to visit multiple clinicians. Historically, electronic medical records, they are siloed within individual healthcare providers. Every doctor, clinician look at you, capture the data, and keep it in their own IT system. Next time you go to another doctor, they don't have data from your previous doctor. Traditionally, this is just not shared. It's a siloed system. And this has led to care fragmentation. By having a centralized data repository, we can minimize errors. For example, once it's recorded you have a drug allergy, every doctor you see will know. You reduce the chance of an error where a doctor may give you a drug that you might be allergic to because the data is not shared. We can remove frustrating repeated testing. You test at one doctor, you go to another one, they don't have the data, test you again. So those repeated testing can be eradicated. We can make care much more integrated and seamless, and overall improve patient outcomes. Another major benefit is that the data sets in the NEHR, if we properly process them, anonymize them, and then securely use them for research to generate important insights, including using that to train AI models to deliver predictive preventive care that I mentioned. Singapore has already established a platform that we call Trust to properly do this safely and securely. So data integration and centralization is an important topic. When I go overseas for healthcare conferences, this is always a subject that I will discuss with fellow health ministers all around the world. And I realize that many countries also recognize these immense benefits, and they are working on it. But most of them are quite far away from having a working system because their IT systems are fragmented. Every individual doctors and clinicians have their own IT system, and it's not linked up into a central healthcare record system. Certain EU members, such as Estonia, Norway, they have working systems, and they are the envy of many countries. In that sense, Singapore's position is closer to Estonia and Norway, where we already have a centralized system in NEHR. So these are the few countries that are just ahead of the pack. What we are missing in Singapore is legislation that mandates all healthcare providers to contribute essential data of patients into the NEHR. The system is there. Now we need to mandate that all doctors contribute into it. The majority actually already do. Let me just elaborate a little bit. So for primary care, polyclinics all use NEHR and contributes to it. Private GP clinics on Healthier SG, as a condition for joining Healthier SG, all contributes to NEHR. Together, they account for about 70% of the primary care sector if we exclude those doing aesthetic services. So already 70% is already on. As for acute hospital care, usually inpatient, public hospitals handles 90% of our hospital workload, and they are already contributing to NEHR. Private hospital, the remaining 10%, are not yet on board. So therefore, we have 70% of primary care already on NEHR, 90% of acute hospital care already on NEHR. So it is a minority comprising private healthcare providers still not on NEHR. The new legislation that we call Health Information Bill will require them to come on board and help us realize the full benefit of a centralized data repository system. We have already consulted all our private hospitals, and they have unanimously supported coming on board NEHR. Later today, they will be issuing their statements to convey their support. And some have already started working with MOH to prepare their IT systems for connection and interoperability with the NEHR. We hope to pass the legislation early next year, but notwithstanding, patients should be able to exercise their individual choice to opt out of having their essential medical data shared under the NEHR system. It is not ideal in terms of providing care for them, but there are various reasons why some individuals may prefer not to share their data, and we'll have to respect their choice. But there's no doubt that as healthcare providers, everyone should contribute to it. So in closing, there's much promise in population health to transform health and to promote preventive care. But provided data is available and research is empowered. In Singapore, we have a holistic strategy to harness the power of information to transform healthcare, and we are actively doing so. I look forward to the continued contribution of SPHS in this exciting journey ahead. Thank you.
Good morning, guests of honor, Mr. Ong and Dr. Kenneth Mak, our DG of Health. And special morning, good morning to all of you, the most important guests, our cohort participants. Some of you were even here from day one, 20 years ago. Let me start today by telling you a story. Right? Today, we kind of taken it as a fact that smoking kills. But surprisingly, many years ago, this is not the case. Many, many years ago, there are advertisements that say, smoking is good for you. Smoking relieves you from chronic bronchitis, from asthma, from influenza, right? Not only that, doctors appear on smoking advertisements and doctors smoke. Today, if I go on this advertisement, our DG of Health will come after me, right? And in fact, the person who discovered that smoking caused lung cancer, he himself was a doctor, and he was a smoker. He actually said, I did not expect cigarette smoking to be the cause of the problem. I thought it was the tarring of roads and motor cars, right? And he discovered by doing a cohort study, which we today call the British Doctor Study. What he did was he got about 34,000 male doctors and just very simply asked them, are you a smoker? So he ended up with two groups, one group smoker, one group non-smoker. And after a few years of follow-up, he found that among the people who smoke, the doctors who smoke, quite a lot of them developed lung cancer and died from lung cancer compared to the non-smokers. Not only that, those who smoke more were higher risk of developing and dying from lung cancer. Now, this finding caused some of the doctors to stop smoking. So we end up with three groups: the smokers, the ex-smokers, and the non-smokers. And interestingly, once they followed up, the ex-smokers have death rates that are somewhere in between the non-smokers and the smokers. This British doctor study went on for 50 years. And after 50 years, the conclusion was that if you stop smoking at the age of 35 onwards, your risk for lung cancer drops down to that of the non-smokers. It's as if you never smoked in your life, right? And even if you stop smoking at 60 years of age, it actually dropped down by half, right? So it's not too late to stop smoking. So this British doctor study used what I call talking information. They just ask questionnaire. Just ask question, are you a smoker? You're not a smoker. What if we actually have more accurate kind of data, more objective kind of data, like your blood test or various clinical tests, what I call tissue information. Yeah? If we have tissue information on top of talking information, wouldn't it be so much better? And there was one such study, this time in the US, called the Framingham Heart Study. And essentially, they recruited these subjects and not only take talking information from questionnaire, they did clinical examination, and they did blood tests. 10 years later, they found that high blood cholesterol increases the risk of heart diseases. Something that we took for granted today that we know, but it came from a cohort study, that high cholesterol level increased the risk of heart disease. How about Singapore? We started a cohort in 1993 called the Singapore Chinese Health Study, started in the school by Professor Lee Hin Peng, Professor Mimi Yu from University of Southern California. This is a recent photograph that we took. At that time, 1993, they don't look like that. Right? They were much younger and the hair was still black. Right? One of the focus was they recruited 63,000 Chinese to be able to look at diet, chronic diseases, especially cancer. And after 10 years of follow-up, one of the major findings that came out from it was that among females who are non-smokers, there's also a risk of lung cancer. But soy products, soya bean products, actually protects females who are non-smokers from lung cancer. Right? Now, because the Singapore Chinese Health Study is mainly on Chinese, the school decided to start a multi-ethnic cohort. We called that at that time multi-ethnic cohort. Today we call it Singapore Population Health Studies, right? And you remember, you came down, we collected talking information, we collected blood samples, urine samples, and performed various tests. And not only that, we asked you, please come back again, right? So a lot of you came back again and again and again, every couple of years, and we'll be able to track the changes. So cohorts of today are usually multi-ethnic, multiple time points, you come back many times, and we collect multiple biological specimens and we store them, right? And to increase the size, we actually have multiple collaborations with other studies, with other cohorts. So much so that cohorts are so important that they no longer come under the control of a single researcher. We see it as an important national resource to be able to study how lifestyles and gene work to affect our health. Let me give you one example of how we made use of repeated visits. So from your repeated visits, we collected information about your BMI. And here, each of the line represents a specific individual and how their BMI changes over time. Many went up. Some remain constant. Very few went down. But it is this individual data points that is very important, because from that we can be able to study how changes actually affects our health, but more importantly, also helps to project future burden of diseases. Dean earlier on mentioned about the cohort data that used for war on diabetes. And that's what we did. We took your individual level data and ran what we call simulations. If all of us just age and don't get fat, by 2050, there will be only about 460,000 diabetics in Singapore. But because we are getting older and fatter, we end up going to have 1 million diabetics in Singapore, right, in 2050. And that was one of the evidence that was used for the basis of the war on diabetes in Singapore. Cohorts of the future will not only have talking information, tissue information, but also tracking information. Minister mentioned about the use of trackers. And trackers, all of us almost use it. We not only measure our steps, we even input what we eat, and then our mood even, how we feel. So lots of information. What this opens up is that I can make use of talking information, tissue information, tracking information to see how they influence the risk of diseases. But it also opens up a new opportunity. It opens up the opportunity to modify the behavior of our cohort participants to give you personalized program. That's like what is being done with Healthier SG. And we can track that progress. Now, when it comes to changing behavior, a lot of times we feel that we need to give people knowledge. And knowledge will drive behavior. If I know what is good for me, if I know what is bad for me, then it will change behavior, increase knowledge. That works to a certain extent. And then we try to give incentives and provide nudges so that people at the point of decision can make the right decision. It resulted in some degree of success. But I think what happens is that it results in what I call superficial changes. In other words, when it comes to difficult times, we actually fall back to what we are used to. What we should target now is deep changes. And I think there are two other factors or two other conditions that will help us to go into deep changes. One is our value system, and second is our attitude, right? We need a population that value health just as much as wealth. We all value wealth, right? But we must value health just as much as wealth. We need not only our generation, but newer generations, especially the young, to grow up valuing health just as much as wealth. Secondly, in terms of attitude towards healthy living, I don't know about you, but most of us will feel healthy living is kind of an imposition. It's kind of a chore. Can we come to a stage whereby we find healthy living is shiok? Right? We need to have that internal drive that we find actually healthy living is actually shiok. Right? And I think to bring all this together, one key approach is to use the emotions that is stirred in us, right? To stir positive emotions in us. And with the technology of today, with augmented reality, virtual reality, with AI, it is possible to come up with programs, interventions that stir positive emotions in us, right? So cohorts of the future will not only be discovering diseases, risk factors for diseases. Cohorts of the future will help to develop personalized behavioral interventions. Cohorts of the future, with your participation, will benefit not only future generation, but current generation, will benefit yourself. We want all of you to be able to value health just as much as wealth and to find healthy living shiok. Thank you.
I'm looking up in the back of the room because some of you may have come in to this study 21 years ago. Seng has given us a sort of a really nice sort of overview of how these sort of cohorts have come along. And when Ling asked me to do this talk, I decided to tell you my story because you've told me your story. And the story begins like this, and you've heard part of this already. It begins in a little town called Framingham, and this is where it is. It's up in the northeast of the United States, just north of Boston. It's not very big. They have about 70,000 people. And even today, it's not very highly developed. It doesn't look anything like New York or Los Angeles or Singapore. But in 1948, the US government decided, soon after the death of President Roosevelt from some sort of vascular disease, we need to understand what the causes are of heart disease. Why do people get heart disease? And what Seng didn't tell you is that the original budget for the Framingham Heart Study in 1948 included salaries of doctors and nurses to make the measurements. But they also had a specific item for ashtrays for the doctors who were supervising the study. And it wasn't until 1957 that they first reported that high cholesterol and high blood pressure increased the risk of heart disease. It feels like we've known this forever, but we didn't. And just like Seng showed us, when Richard Dahl showed us that smoking leads to lung cancer, in 1960, the Framingham Heart Study reported that cigarette smoking increased the risk of heart disease. And you'll realize that when Minister talks about healthier SG, half the components of your health plan come from this study. One of the things that I thought I would show you is this idea, right? And one of the, that when we deal with high cholesterol, now that we know that it's a risk factor, today we have medications that can bring cholesterol down, right? And this is one study, one of many studies that basically shows that if you have high cholesterol and you don't have heart disease, right, which is, I hope, many of us, that your risk of heart disease will reduce by about 24% if you take one of these medications. But medications are not for everybody. Right? There's a reason why we don't put these medications into the water supply the same way we put fluoride in to protect our teeth. And the reason is because all medications also have some risk. And it's our job when patients come into the clinic to evaluate that risk. And the story has always been that we need to give the most intensive treatments to those people at the highest risk. And in fact, if you look, this is something that is actually, it's on every doctor's desk today. And what it shows you is that the higher your risk, the lower your cholesterol needs to be, and only when you get into the intermediate and high risk do we really think about giving people medication. So when you go for your health screening and your doctor says you do or you don't need medication, what they've done is they've calculated your risk. And the question is really, well, how do they do that? And this is the data that came out of Framingham in the 80s and 90s. What it turns out that after they discovered that high cholesterol is bad for heart disease, and high blood pressure is bad for heart disease, and smoking is bad for heart disease, it turns out that if you measure these things, you can give people a score, and you can estimate the risk of heart disease. And in this case, what you're seeing is the risk in men and the risk in women. This is being used in Canada, but it's also used across North America. So I'm going to turn my attention now to sort of another little red dot. So I went to Framingham in 2001, and I came back in 2002. We started, Jeanette and I, so Jeanette sitting up in front here, Jeanette Klising and I remember meeting in the school at that time, which was a department, it wasn't a school, and thinking, you know what, we need to be able to do the same calculations in Singapore. But ours is a multi-ethnic population. And we know that not only do men and women in Singapore have different rates of heart disease, it's also different in Chinese, Malays, and Indians. How can we possibly take the risk functions that were developed in a predominantly white population in Northeast America and use them in Singapore? And the answer is that we can't. And maybe Stefan, we never acknowledged Stefan on this, and Stefan, I'll ask you to sort of put up your hand for a moment, because Stefan Ma, this is, ever since 2006, this has been on the desk of every doctor in Singapore. Next time you go for your Healthier SG health plan, point to this thing and tell your doctor, you only have this because of me. And you'll see, not only do we have risk calculators for men and women, we have risk calculators for Chinese, Indians, and Malays living in Singapore. One of the things that's important, and Kee-Sing talked about studies that go on for 50, 100 years. One of the things that's important is that health is not static. The health of the population changes over time. And what I'm showing you actually is that between the 1990s and the early 2000s, actually the heart disease, it doesn't feel like it, but the rates of heart disease are coming down. Let me tell you, first of all, as a physician, it got nothing to do with me. It's got nothing to do with me. It's got everything to do with the way that we lived our lives, the ways that food's changed, the access to sort of good quality food, exercise, reduction in cigarette smoking. But as these things come down, we have to be able to continue to evaluate risk appropriately based on what's happening in the population today. So this guy, hang on, I've seen this face. This guy recalibrated our Framingham function today. And this is what's in use today. This was released in December 2023. And again, those of you who did your health plan this year, point to this thing on your doctor's desk. This is a direct photo from the thing. It's not, you'll recognize it, and you tell them, remind them, none of this would be there if not for the people in this room. And you can see that actually the risk is a little bit lower. But again, it's going to change over time. And this is a projection from some colleagues of mine last year. And it's really interesting. So those things that we know something about, cholesterol, blood pressure, cigarette smoking, actually we will start to see a reduction in heart disease that actually is due to these factors. What we haven't been able to do is deal with the fact that many of us are gaining weight over time. And this, in fact, we think that this will drive a second wave of heart disease. And we need to make sure that we understand it and develop things of the nature that, like he says, we need to understand what people's values and attitudes are. Because, as you know, there's one saying, what good is health? You can't buy money with it. So I'm going to finish off with this. And this goes back to the sort of whole story, that each of us will have a different experience of health in our lifetime. We look forward to many people as we get older, living lives that look like this. But we know that some of us will develop other conditions and we will continue to live, but we won't live with the same quality that we had before. And sometimes it will hit us early. Right? So this lady is only 50 years old when she had her first stroke. And 50 years old is the time most of us are still looking forward to our retirement. In fact, the first heart attack in Singapore still occurs in men at the age of 67, and 67 is our retirement age. What does that mean? It means that 50% of all heart attacks occur before people reach their retirement age. And when we think about health, what I'm hoping for you to recognize is that actually healthcare provides only a very small portion of this. About 1/3, and Seng talked about this as we start to decode our genetics, about 1/3 is actually in our genes. We get this from our parents. And what I'm showing you here is now some data from the National Precision Medicine Program, but I can see JJ taking a photo, but this picture actually came from JJ Liu. And what you're seeing is several thousand of you mapped onto the world population. So these are people from Africa. These are people from Europe. These are people in yellow from East Asia. And then these big red blobs here are people from the Singapore population. These are Singapore Chinese. These are Singapore Indians. And this group here is almost completely unrepresented in the world data sets that we use to understand genetics today. And this is our Malay population. Right, so Singapore provides the largest data set for Malays' genetic data in the world. We're the major contributing to the understanding of how genetics affects these individuals. And 40% of these variants are completely new. They reflect our ancestral history. They come from where these tell us a story about who our parents were, who our grandparents were, where they came from. This is our ancestral story. But our health is also determined by many, many other things. By the food we eat, by the environment that we live in, and to some small extent, by the healthcare system. It's really important that we recognize this because the genetic part, it tells us something about what our health is going to be, but we can't change it. You can't choose who your parents are. What you can do, all of these other things, then become the tools that we can use to take away the risk that came with our genetic history. So these are all the things that will reduce risk in the future. So this is my final slide, and I just wanted to remind you, we started this in 2023, so this is actually the 21st anniversary. The reason we call it the 20th is because I didn't do anything about it, and Ying had to sort of get me up and sort of moving. But what you've done, right, is share details of your life with us that actually none of this work that we've been able to do would have been possible without it. I said that this is a personal story. When I returned from Framingham in 2002, we began this, and it's been 21 years. And I've grown up and grown a little bit older, only a little, not 20 years, but basically spending my time trying to unpick, right, what's going on here. And you're already seeing it, right? You see it every day, every time you go and see a doctor, you see these things on their desk. They're making decisions based on data that you contributed. And you're already seeing how this contributes to healthier SG. But just remember that there's no population like Singapore. There's nowhere else in the world where Chinese, Malays, and Indians live together in an advanced, developed country and has health experiences that are more like European countries than anywhere in Asia. Where we will tell the rest of Asia what will happen to them as they develop. And so it's not just about healthier SG. It really is our contribution to a healthier world. In the same way that Framingham and the British doctors study, they started in their own little town, but they've helped us improve the health of the whole world. Thank you.
Hello, good morning, and a privilege to be here. I'm going to switch gear and talk about diet and hopefully food, hopefully people's favorite topic. Also to whet your appetite as lunch is coming up, okay? So I'm going to share with you, take this opportunity to share with you some of the diet-related findings we have gleaned from the cohorts. Okay, so those of you who have been with us, right, about 20 years back, so the findings that I can share with you today are really thanks to you cohort participants who have been with us. If you recall, 20 years back, we were collecting a nutrition survey from you, what we call scientifically food frequency questionnaire. A long questionnaire asking you a list of foods you eat, how often you eat, etc., right? And in recent years, we have advanced to something, an online version where we're asking you through like basically food pictures. So again, many thanks to you all taking time to sit down with our research staff here, our clinical staff, to tell us what you have, and that's why we're able to collect data. And many thanks also to our IT team, which also transformed previous methods of collection through pen and paper to more using more advanced methods through the app. And again, also to you coming back for measurements that we can take from you, blood pressure, etc., blood pressure, and therefore able to collect these indicators of heart disease. So what have we learned over the years, over the 20 years, right? So 20 years ago, when we looked at the data of what our cohort participants were eating, we saw two main dietary patterns. One, which is general healthy pattern, and another one, which is characterized by noodle and red meat. But in recent years, when we look at the data from our population here, we actually see four patterns emerging, and these were the four patterns coming up. Right, telling us that actually our populations are eating more diverse diet. But what's interesting for us is that when we look at the three ethnic groups, right, Malay, Chinese, Indian, we see these four patterns actually being consumed by our three ethnic groups and those in the others as well. So really telling us that in Singapore, which is multiracial, multicultural, our eating patterns are actually quite similar. It doesn't mean that we are from a certain ethnic group, we eat a certain kind of food. And this is a very important message to us as public health professionals or even clinical professionals, like when they give advice, to not assume that, okay, just because you have a patient or a participant from a particular racial group, they only eat certain food. Actually, in Singapore, we should eat across ethnic groups. And I think as the world becomes more cosmopolitan, this is also the case, right? Where we don't just silo person to their own cuisine or ethnic cuisine. And then when we related this dietary patterns to heart health, we saw two patterns, okay, that emerged that relate to that gives us heart benefits. So we have the pattern, the ethnic breads, legumes, and nuts pattern we found, right, that these were found in people with low cholesterol levels. So this is associated with lower cholesterol levels. And then people who consume diets of which has higher whole grains, fruits, and low-fat dairy. These were the people with lower risk of being overweight, lower risk of having high blood pressure, and high cholesterol, etc. And this message is very important because it's telling us that we do not have to follow Mediterranean diet. It's been very popular. Just to to get a healthy diet, okay, just to get protection from heart disease. In fact, there are different ways to have a healthy diet, like what the data is showing us. And these ways can be achieved by eating foods that are familiar to us, right? We don't have to purposely go out to go and consume a Mediterranean diet just to be healthy. In addition, right, there were other data that came out from the cohort telling us that within our population, if we have moderate carbohydrate intakes, plus have higher good kind of fats, what we call polyunsaturated fats, and have good quality carbohydrates by replacing things like white rice, what we call refined grains, with whole grains, fruits, vegetables, and dairy, these actions can confer health benefits like, for example, preventing us from gaining too much weight and other heart health benefits. And such findings are important, especially in the light of very popular and trendy diets now. You may have heard of things like keto diets, paleo diets, or low-carb diets, which are telling us to cut out carbohydrates or take very low carbohydrates so that you can lose weight or have very good benefits, right? And yes, in the literature, these diets have shown to have benefits, okay, various kinds of health benefits, but the evidence is telling us these benefits are mostly short-term, right? And the long-term benefits are really very unclear or unknown at this point in time. But what we know is that if we do follow such low carbohydrate diets for a very long time, these actually end up giving us negative benefits. Negative effects. Okay, for example, taking low carb diets, again, some of the more immediate negative impact would be fatigue, constipation, headache, or increasing your risk, okay, of gout, of kidney stones. The more medium-term negative effects will be nutritional deficiencies, making you deficient in nutrients. If you choose the wrong type of foods, you may end up even having heart disease, okay, from taking too much red meat, full-fat dairy products. And we know that such diets are not very sustainable, they're expensive, very challenging to maintain. So then, do we go for plant-based diets then? Another very popular kind of diets you may have heard of in the news, right? Is this the diets to go for So what are plant-based diets, or to many people, vegetarian diets, right? And then there's a whole myriad of different kinds of vegetarian diets out there, from the more kind of extreme vegan, where they avoid all kinds of animal products, to flexitarian, where they do consume some small amounts. So again, people take plant-based diets for different reasons: environment, health, religious. So in general, okay, regardless of the different definitions, what is defined as a plant-based diet is basically a diet that emphasizes a high intake of plant-based food while limiting the intake of animal products. And if you look at this literature, yes, okay, the benefits of plant-based diets has been well known, right? Has been shown to confer many health benefits, but most of these studies tend to be comparing vegans, okay, or very strict vegetarians versus people who take meat and fish products. And often enough, these are studies from the Western countries. So how about in Singapore? You know, would taking plant-based diets be healthy for us? So to me, growing up, this was what a vegetarian diet is. Okay, you may be familiar with a vegetarian bee-hoon, where, well, I always look forward to my, fried beancurd skin, mock meat, and spring roll. So it really brings to mind to say that, really, are all plant-based foods really healthy? And are there undesirable effects? If we say, okay, forget about the meat, let's just consume all plant-based diets. So again, we look back to our cohort data to simulate scenarios to say, okay, what happens if we replace these animal foods with plant-based foods? What would the impact be on our nutritional status? So this is what we found, that if we replace fish, okay, with plant protein foods, so basically nuts, legumes, grains like rice, or if we replace the meat we eat, the chicken we eat, all of that with, let's say, just refined grains, what we end up having is a higher risk of vitamin B12 deficiency. Now, on the other hand, if we replace processed meat, processed seafood, right, with things like vegetables, with nuts, seeds, and legumes, that's actually beneficial because it actually increases our folate intake. Okay, so, yeah, right? And then finally, I want to move on to diet in the later ages, right? As we go through to the aging period. The question I wanted to ask is it too late, right, to improve my diet at midlife? And midlife is around 50s, right? By 50s, if I change my diet, then is it actually beneficial? So we looked at the Singapore Chinese Health Study, okay, for the data, and we looked at how our participants at 50 years of age, and then we observe them until they're about 70 and see how they change their diet and how that impact on their aging outcomes, right, at around 70 years of age. And this is what we found. So for people who have been having a healthy diet pattern consistently, okay, as well as people who have improved their diet from 50 years old onwards and continue even to 60, these people, compared to those who have been just following a less healthy diet pattern, these people have much better health outcomes in terms of physical aging, cognitive domains in aging, mental aging, compared to those, right, who do not actually improve their diet pattern. So telling us that actually it's not too late. Even at 50 years old, previously you weren't following a very healthy diet. At 50, you start to change. That itself can also confer benefits, and you reap that at 70. So in conclusion, right, I just want to say that really the findings we have important implications in terms of how we develop recommendations and guidelines for Singapore, telling us that actually in general, right, for most people, a moderate carbohydrate diet following a healthy plate is sufficient. You don't need to go and cut out your carbohydrates or go for extreme low carbohydrate intake. You do not have to completely eliminate meat, right? Health benefits can be achieved even with small reductions in animal foods and increase your healthy plant foods in diets. And most important, it's never too late, right, to improve our diets for health benefits in later life. Okay, with that, thank you very much.
Hi, everyone. It is my absolute pleasure to be here with you today. I flew back from Bangkok last night from a meeting with many people around the world who were working on infectious diseases to try and understand how we can better control and improve health. And I'm excited this morning to be in another room full of people who have spent their lives working to improve health. And it's a real honor for me to be here speaking with you today. I'm aware that I'm between you and lunch, and we've just seen pictures of food. So I'm going to keep this very brief and just tell you a little bit about infectious diseases, how we study them. I'm aware that I don't need to tell you about COVID, so I'm not going to. I'm going to talk more generally about infectious diseases and have a think about how, everything we've heard today about the cohorts that have been developed and that have been used here have been for studying non-infectious diseases. And I'm going to tell you a little bit about how we might make changes to what we need to study and in order to learn more about infectious diseases. So here's some posters that may or may not be familiar to you. I think the first two probably are very familiar, talking about dengue, COVID, and hopefully the Mpox one is less familiar and will remain less familiar to you. I've spent much of my career working on dengue and trying to understand how dengue spreads and how we stop that spreading. But I want to just talk a little bit about how the research that goes on behind the scenes in order to determine how is it that we come to these posters? How do we know that this is the best way to protect ourselves and our communities from infectious diseases? So there's a number of questions that we as researchers ask ourselves when we're thinking about infectious diseases. And as you can see, these are quite different from those that we ask ourselves about the other diseases we've heard about today. So infectious diseases, we want to know how is it being spread? Where is it being spread? Who is most likely to get it? How fast is it being spread? Who is most likely to get sick? So as you can see, some of the similarities, but of course, with this spread from person to person, there becomes differences in how we look at the diseases. I spent my large chunks of my life thinking about this one number, which is really important to understanding infectious diseases. And it's essentially, if I can get the pointer to work, telling us if someone is infected, how many other people do they infect, right? And we've all become very familiar, unfortunately, with this through COVID, thinking about how much spread is going on in the population, how is it going through, and those kind of questions. But we don't just need to know that because it's interesting. We need to know it because it tells us how much we need to do to bring down that spread of the disease. How much do we need to change our behavior or have other interventions in order to stop that spread as much as we would like. And so what we can do is that we can protect ourselves through many ways, and I'll talk more later about what those ways are, in order to stop ourselves and people in our communities getting infected. So we can, in many ways, put these kind of bubbles around ourselves, and we became a little familiar with one of the ways that might work, or a few of the ways that might work during COVID. But this is a whole lot of sort of research going on to understand exactly how much to do that and what are the best ways to do that. So we've been talking a lot about cohorts, of course. Some ways we can do this are within cohorts. There's also household studies. We heard about this linking up of the different medical records that's been happening across Singapore. That's also all really useful for us to understand how this can spread. And so when we're looking at those kind of studies, we always then have in our mind, okay, once we know these things, what can we do to control it? And there's a whole long list of things that I hope you are fairly familiar with, unfortunately, now, that we can do, right? I've written vaccines at the top. That's one of the really important ones, and I'll talk a little bit more about vaccines. But we've now become very familiar with the concepts of isolation, quarantine, mask, hygiene, testing, border control. But all of those, in order to know that those were effective, we had to know how's the disease spreading, how much is it spreading, where's it spreading, who's it spreading to, so we could figure out, is it going to be useful to wear a mask? Is it going to be useful to isolate at different times and those kind of things? So I said I'd talk a little bit more about vaccines, and this is a figure, unfortunately, from the US, but it's sort of dividing the time in what they call the pre-vaccine and the vaccine era. So there's a whole lot of diseases here that we don't have to worry about, we don't have to think about in our daily lives, and that is because of vaccination. And so many of you will have had these vaccinations. You will be taking your kids for these vaccinations. I have an appointment with my 1-year-old on Tuesday to take her for some of these vaccinations. And they have become a really vital part in the control of infectious diseases. And I think this is one of the reasons that pre-COVID, a lot of our time moved away from infectious diseases, because most of the time, a lot of them, we worried a lot less than we did before. But that's not to say that with COVID, of course, and with other infectious diseases, there are not those still spreading. And one of those that I just wanted to end on is thinking about RSV. So RSV, actually, most of you might never have heard of, which is a good thing, but it's actually quite a serious disease. And as you can see here, there is now, for many people in the population, a vaccine that's available. And this is so exciting. When I started reading about this new vaccine, I was very excited about what this will mean. So you might be hearing more about this soon, and I just wanted to flag that to come. And again, we spend a lot of time learning about RSV in order to get to the point of having this vaccine that could go into the arm of this very important gentleman in the picture. So I'll end just on a quick summary of infectious diseases. It's sort of taken us away from what we've been thinking about today, but of course it's been something that we've all spent a lot of time thinking about over the last few years. So I hope that if anything comes up again in the future around infectious diseases in the cohort, you'll be interested and excited to learn more. And with that, I will stop, and I think you're not too far off lunch now. So thank you for your time. And